Good morning, everyone, and welcome to our webinar. Today's topic is Lewy body dementia, navigating diagnosis, care strategies, and essential support. We appreciate all of you joining us today. These complimentary webinars are brought to you through a collaboration of sponsorship with O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, as well as Alzheimer's Orange County. My name is Kim Bailey, and I'm a gerontologist here at ALS OC, and I will be your host today. Our sponsors are providing these webinars to you as a service to the community on topics that are beneficial to anyone who cares for and works with older adults. We hope you find today's presentation especially useful and informative. And today we have a wonderful speaker, Rachel Rose, who is from the National Lewy Body Association. So in just a few minutes, I'll tell you a little bit more about her. But before I do that, let me review with you what you need to know if you're interested in earning continuing education for today's seminar. So, CE credit is available for RCFE administrators, licensed RNs and LVNs, and for LMFT, LCSW, LEP, and LPCC professionals through CAMP and the BBC. You must be online for the full 60 minutes. You must have access to both audio and computer. If you want CE credit, you can't share your link with others. It's your unique record of attendance. So if you do happen to share your link or use another attendee's link, you will not be able to get CE credit. Please answer the poll questions immediately. This is proof of your active attendance. If for any reason you have difficulty accessing or answering the poll questions, please type your response into the chat box so that we know that you are actively attending. If we don't get any response from you, unfortunately, we're not able to qualify you for CE credit. Please complete this survey immediately as we end the webinar today. You will only receive a survey link by email if you do not complete the survey when exiting today. The email with the survey link is sent out 24 hours after the end of the webinar. And this link, again, is unique to you and your attendance, so please don't share it with others. Some basics for everyone. Your mic and your video are automatically disabled, and it will remain so throughout the presentation. But you will have the opportunity to ask our presenter questions about the topic, and you can do that by putting your questions into the chat box. We will save them and hold them for the end of the webinar where we'll have our little Q&A format. So if the Q&A session runs long, you are welcome to stay for that. But if you're requesting CE credit, you're only required to stay for 60 minutes. So just a point of clarification there. So again, remember to complete the survey immediately as you exit the webinar. And I forgot to mention that your certificate of completion will be issued to you via email within 10 days of your completed survey being received. So with all that said, it's time for me to introduce our speaker for today. She is Rachel Rose. She serves as Education Manager at the Lewy Body Dementia Association, where she oversees the development, implementation, and evaluation of evidence-based education programs, resources, and initiatives for people living with Lewy body dementia, their care partners, and healthcare professionals. She is an experienced occupational therapist specializing in outpatient neurorehabilitation, and she's practiced at the University of Iowa Healthcare since 2015. Rachel is the lead occupational therapist for the University of Iowa Healthcare System's interdisciplinary movement Disorders Clinic, a Parkinson's Foundation Center of Excellence, and continues to provide care as part of this team. Since 2019, she has served as OT faculty for the Parkinson's Foundation Team Training Program. Passionate about education, Rachel focuses on empowering individuals living with neurodegenerative condition, their care partners, and healthcare professionals through evidence-based resources that enhance awareness and quality of life. And so it's with great pleasure that I turn this meeting over to our speaker, Rachel Rose. Thank you for being with us, Rachel.
Thank you so much for the warm introduction, Kim. And I wanted to give a thank you to Lauren, who's backstage, and for all of you for allowing me to be here today. I'm very honored and excited to explore Lewy body dementia. So, with that being said, let's take a look at our objectives for this discussion. I'll start by discussing LBD, core symptoms, and diagnostic considerations for Lewy. Then I'll go into unique challenges faced by these individuals with LBD and their families. And then we'll conclude by looking at available resources from LBDA that we have on various topics, ways to stay involved, and other supports for Lewy. So before we dive in, I really wanted to start with a bigger picture. What is dementia and how does it differ from normal aging? So as we age, it's very normal to experience mild changes in attention, short-term memory, maybe forgetting a word here or there, or taking a little bit longer to recall something, even like a tip of the tongue situation where it's right on the tip of my tongue. What was it? These changes don't interfere with daily life. And then when we progress to mild cognitive impairment or MCI, this is more than expected for normal aging. But people with MCI can still live very independently. They might notice more frequent memory lapses or trouble with complex tasks, but they can manage their day-to-day activities. And then we have dementia. And this occurs when changes are significant enough to impact daily function and independence. It can be memory, but it can also be thinking, judgment, language, and it really depends on the type of dementia. So understanding this spectrum really helps us to recognize when to seek help and why early diagnosis truly matters. And a common misconception today that we hear quite a bit is that dementia is a single disease, or perhaps dementia equals Alzheimer's. And however, dementia is really an umbrella term that encompasses several of these subtypes shown here. So we have Alzheimer's disease, and oops, I have a little puppy, sorry. We have Alzheimer's disease, and that is the most common form of dementia, accounting for about 60 to 80% of cases, primarily affecting memory and learning. And then vascular dementia, which results from reduced blood flow to the brain, often following strokes or like small vessel disease. And then shooting to the far right, we have FTD, which is a smaller percentage of cases and often begins at a younger age compared to our other dementias, typically around 45 to 65 years. And this primarily impacts our behavior and personality. And the reason I'm here today is we are talking about Lewy body, and that's the second most common neurodegenerative dementia after Alzheimer's. And we anticipate that this approximately affects 1.4 million Americans. So what these conditions share is that cognitive impairment that's severe enough to interfere with daily life. However, the symptoms, progression, and care needs differ significantly. And so that it's very critical for an accurate diagnosis. And we'll get a little bit more into that in a few slides ahead. So let's get into some statistics. So we often refer to Lewy body dementia as the most common form of dementia you've never heard of. So despite being the second most common neurodegenerative dementia after Alzheimer's, it frequently is underrecognized and misdiagnosed. And as I just previously mentioned in the last slide, with 1.4 million Americans being impacted, most of them are over the age of 50. And then studies show that LBD not only is challenging to diagnose, but it is also the most expensive form of dementia. And that can be in part by individuals with LBD often experiencing more severe functional impairment, which leads to higher care needs and increased healthcare costs. So much of this cost difference is driven by hospitalizations, often related to falls, urinary symptoms, depression, anxiety, psychosis, blood pressure, and sleep disorders. And so early accurate diagnosis matters, and it's not just for quality of life, but to reduce the unnecessary hospitalizations and improve care planning.
Okay, it is time for our first poll question. And that question is a true false. LBD is the most misdiagnosed form of dementia. Audience, is that true or false? Go ahead and quickly weigh in so that we can go ahead and get back to our presentation. Again, the statement says LBD is the most misdiagnosed form of dementia. Okay, it looks like people have had a chance to weigh in. And as we release those results, it looks like the vast majority of folks got that right. So good job. And back to you, Rachel.
Thanks, Kim. So this slide highlights the many names and just some acronym examples that you might hear when talking about Lewy body dementia. So whether that's in the clinic or you're watching a webinar like today, or maybe in a podcast. So you might hear Lewy body dementia, Lewy body disease, DLB, LBD, Parkinsonisms, and this can feel a little like alphabet soup. And it can feel very confusing. So hopefully I'm going to clarify a couple of these definitions and how they all interact in the next slides. So with this slide, I want to direct your attention to that upper right-hand corner. This image shows what a Lewy body looks like within a brain cell. So these Lewy bodies form when a protein called alpha-synuclein, which is normal in everybody, but for some reason it misfolds. And we don't know exactly why. But when this happens, that protein can get really sticky and it can glom up, kind of glum together. And then the cell starts to wall it off. And then we can see these circular inclusion bodies that you can see here. And these were first discovered by Dr. Frederick Lewy in 1912, where he described seeing these little circular bodies in cells within the patients that had Parkinson's. And then the term Lewy body was actually coined several years later from a few other neurologists. And a side note, because I'm a historical buff, Dr. Lewy spent some time working in Alzheimer's lab, so earlier in his career, which is an interesting topic and a webinar topic for another day. But these Lewy bodies, when they misfold and they clump together and they can spread throughout the brain, and then where they are located can cause different symptoms. And this is why Lewy body can be unique for individuals and why it can change over time in a very unique way. So maybe you've heard the saying, if you've seen one person with Lewy, you've seen one person with Lewy. And that is really the case. So again, when these clumps are present, we often then talk about Lewy body dementia. And this is also an umbrella term. So we have dementia as an umbrella term with our subtypes, and now we have Lewy body or LBD, and it has two subtypes. So you can see here the far left being Parkinson's disease dementia, and on the right we have dementia with Lewy bodies. So starting with PDD, it usually gets diagnosed when someone has well-established Parkinson's disease. And then maybe 1 year later, and often many years later, they develop this certain specific type of dementia, which we'll go into. So they have a lot of what we call Parkinsonism. So the shakiness, slowness, rigidity we see in Parkinson's. And then on the other hand, DLB, the individual must have dementia first, a specific type of dementia. And then at the same time, the individual develops dementia, or maybe at least a year later, and even in some folks, never at all, then the motor symptoms or the Parkinsonisms may occur. So the two main differences between these two subtypes is really the timing. Does the movement symptoms come first, and then about 1 year later, the dementia comes? We name it Parkinson's disease dementia or PDD. And on the other spectrum, DLB is dementia comes first at the same time or a year later, the Parkinsonism symptoms occur, then we call it DLB. And that 1 year rule is really an arbitrary way to kind of distinguish between the two. And there's been debate whether these two should be lumped together or maybe split apart, but they remain split as these two categories do have very unique presentations and a lot of differences along the course of the disease. So, talking about Parkinson's disease dementia or PDD, for individuals living with Parkinson's disease, cognitive changes can develop over time. So, in fact, research shows that from 50 to up to 80% of people with Parkinson's may develop dementia during their lifetime. There is a small portion of folks who don't, but this 80% is quite large. And the risk is 4 to 6 times higher compared to people without Parkinson's disease. So often before dementia develops, there may be a stage called a mild cognitive impairment in PD or PDMCI, where thinking changes are noticeable, but daily independence is still maintained. And that's why it's so important for everyone with Parkinson's to have their cognition checked at least once a year. Early recognition really allows families and clinicians to plan ahead, adjust care strategies, and support quality of life.
Okay, and it's time for our next poll question. With advancing disease, up to 80% of people with Parkinson's disease may develop dementia in their lifetime. Audience, is that true or false? With advancing disease, up to 80% of people with Parkinson's disease may develop dementia in their lifetime. Okay. Go ahead and select your answer. Once again, if you're having any difficulty with the poll question, with submitting your response, you can feel free to put your answer into the chat box. Thank you so much. And it looks like we're ready to release the results. And once again, you did fabulous, audience. So I'll hand it back to Rachel. Thank you.
And now, looking at dementia with Lewy bodies, this condition is underrecognized and underdiagnosed. On average, it takes folks about 18 months and three different doctors to finally receive the correct diagnosis. DLB is often misdiagnosed form and it's also the most expensive. And why that is because the symptoms can look a lot like Alzheimer's disease in the beginning. They can also look like Parkinson's disease, as we discussed, and even some psychiatric conditions. So, depending on what is tracked or conveyed to the healthcare team or where these individuals land first, it can really lead to delays and an inappropriate treatments. So, many families have never heard of DLB before their diagnosis, and that lack of awareness can really add to the challenge as well, like what to look out for, what to track. And so, this is really another nod to why education is so important. Recognizing the signs early can help avoid unnecessary hospitalization, reduce cost, and improve quality of life for the person living with Lewy and the care partners. And when diagnosing DLB, clinicians rely primarily on clinical features. So in 2017, we had a consortium come together and they established these guidelines. And so to meet criteria for DLB, there must be enough cognitive decline to interfere with daily activities, plus two or more clinical features. And that is that upper horizontal row, which include visual hallucinations. These are often well formed and very detailed, like seeing people or small animals that aren't there, fluctuating cognition, spontaneous Parkinsonisms, and then REM sleep behavior disorder. If someone has one core feature, so one at the top, plus an indicative biomarker, which is the below group of three, then a diagnosis can still be made and it's often coined as clinically probable DLB. And so the indicative features are a positive DAT scan, and that shows dopamine uptake in the brain. However, there might be some false negatives with someone with DLB if they don't have Parkinsonism features. A polysomnogram, so showing that REM behavior sleep disorder is occurring where people are moving during their sleep. And then a cardiac scintigraphy, which is not widely used in the US, mainly in Japan at this time. And while these tests can support diagnosis, they're not always available. So clinical observation and a comprehensive medical review is really the cornerstone of this diagnosis. And one of the biggest challenges with Lewy body dementia is getting an accurate diagnosis, as I've mentioned in the previous slides. And the literature shows us that there's several reasons for this. So first, the clinical picture can vary greatly. So symptoms don't always appear in the same order or at the same intensity, and they can also change over time. So families in this community often ask for stages so they can know what to expect, know how to plan, but unlike other types of dementias, LBD doesn't follow a very predictable path. And unfortunately, researchers and clinicians have just not been able to identify stages at this time, although it is a high priority. Secondly, symptom reporting can be really difficult. So, with hallucinations and cognitive fluctuations, they can be hard to describe or really even uncomfortable to talk about. If we're talking about like a visual hallucination, that's quite frightening for folks. So, imagine seeing something that's frightening or feels off. It's just really hard to kind of track that and share with others. Sometimes the person living with LBD may lack insight into what's happening, which just adds another little complexity layer. And there are also clinician related challenges. So, primary care providers may not be familiar with the complex diagnostics criteria, and referrals to specialists or neuropsychologists for further testing may not happen, whether it being due to not referring or not knowing when to refer, or the healthcare system in general, not with these kind of specialty clinics being backlogged. So, and then lastly, there's just a lack of widely available biological tests. So while promising tools like cerebral spinal fluid assays and skin biopsies are on the horizon, they're just not routine just yet. So all of these factors, these barriers contribute to delays and potentially a misdiagnosis, which is why education and advocacy are so very important. And this slide highlights, there was a study done by Galvin and colleagues that really shows what many families experience. The road to an accurate LBD diagnosis can be long and difficult. So on average, 2/3 of people saw 3 or more doctors before getting the right diagnosis. And for half of the families, it took 12 to 18 months. Another point is most were diagnosed by a neurologist, while fewer than 10% received the diagnosis from a primary care provider. So we think about these rural communities who might not have access to a neurologist. And so these specialties, like I mentioned, they are hard to come by sometimes. So, and then nearly 80% were first told it was something else. And so we have these neighboring diagnoses like Alzheimer's or Parkinson's or the psychiatric conditions. And these delays happen because LBD symptoms just overlap. And if we're not tracking them, we're still growing that awareness, but families can feel quite frustrated and it can be quite isolating. So, and for all the clinicians out there, this is, sharing what we notice with the docs or loved ones, keeping a symptom log, or folks living with this, just making sure you have a tracker, whether it be an app or a PDF template. And so looking at these changes in thinking and movement, sleep, behavior, but we can really help our care team get a bigger and fuller picture. And then this early recognition can really help with better planning. So this tool I wanted to highlight is called the LBD Composite Risk Score, and it was developed for clinicians as a way to screen for LBD, but it can also be really helpful for families and care partners to recognize these patterns. So this is one tool that exists. And for example, if someone answers yes to 3 or more questions, the research suggests there's a strong likelihood about 90% that LBD may be present. So this is pretty significant. And then the questions just on the form really highlight the hallmark symptoms. So the vivid visual hallucinations, fluctuations, acting out dreams during your sleep. And it's important to remember this is not a diagnostic test, but it can really help to start an important conversation. So if you're noticing several of these signs, bringing them to a provider can lead to earlier recognition. And then tools like these exist just to help, again, bridge that conversation gap so people can feel a little bit more empowered during the process. LBDA offers two helpful resources for tracking symptoms easier. So the one on the left shown is a comprehensive symptom checklist. It's designed for families and care partners. It helps to track changes over time. And then the far right is the diagnostic symptom checklist, and that's created more in mind for healthcare professionals. So both are available on our website for download. Um, and they're just practical ways and tools to turn observations into accurate information. All right. So we learned a little bit about what a Lewy body looks like, a little history, the two subtypes. Now we're going to get into some of the main categories of symptoms. So on this slide, in a nutshell, these symptoms vary from person to person and can change over time. So we have the loss of cognitive abilities, changes in movement, behavior and mood, sleep, and dysautonomia. And so I'm going to briefly touch on each of these categories with a few specific examples. So starting with cognition in Lewy body dementia, what we think about dementia sometimes, most people immediately think of memory loss. But with LBD, the picture looks a little bit different. So memory can be affected, but the hallmark changes are often in different areas, such as executive functioning. So that's our ability to plan, organize, and solve problems. So, like following a recipe, planning a trip, this can become really challenging. Also, visuospatial skills, so like judging the distance between cars, maybe misjudging like where an edge of a cup on the edge of a counter goes. Another big one is attention. And attention is the foundation of all of our thinking. So if we're not paying attention, we can't remember, we can't plan, and we can't organize. So people with living with Lewy often have reduced attention and concentration, and that can also mask or look like memory problems, but it's actually something different. We can also see slowed thinking or even disorganized speech. And then one of the most distinctive features for LBD is the cognitive fluctuations. And these are the moments where it can feel like showtime moments, where there's periods of clarity and then maybe followed by confusion or looking like kind of like a zoning out aspect. So these can happen hour to hour within the same day, and they're often accompanied by excessive daytime sleepiness. So when we talk about cognition for LBD, it's less about memory and it's more about these specific domains. I'm trying to bold some of the heavy hitters on each slide. And then more specifically on cognition and Alzheimer's disease, this is a really good article. And if we look at the top graph for Alzheimer's, we notice these red bars right off the bat, right? They're really low. And those are for memory and language. These are the areas often affected with Alzheimer's disease. Now, if we jump to the bottom graph for DLB, these red bars are much higher, right? So meaning memory is relatively better earlier on. But scroll to the right and we see those yellow and blue bars for DLB. Those represent attention, executive functioning, visuospatial, and they're quite low compared if you look up to the above graph. So people with LBD just struggle more with the planning, the problem solving, judging. And I think this is a really nice depiction, and it shows how these two conditions often look opposite from each other. And that's why some strategies that work for people living with Alzheimer's, like memory cues or labeling, just to name a few, might not be as helpful for someone living and navigating with Lewy with some of the visuospatial deficits. So we want to really support attention and support problem solving needs. Another kind of comparison slide. This one shows some of like the initial reports that we might hear. So for Alzheimer's, we may hear they're not retaining new information, maybe repeating questions or comments. I can't remember what was said or what exactly happened. And so these are kind of those classic things we hear with difficulties with storing and recalling new information. Language changes can also appear early, following conversations. And so for on the other side of the spectrum with LBD, we might hear thinking seems slower, maybe losing their train of thought easily, can't keep track of more than one thing at a time, that multitasking. And there's this graphic where we see all these cereal boxes in the aisle. And oftentimes, if there's a cluttered space because of the visuospatial deficits, um, even though their eye doctor says their vision is fine, they're still having trouble seeing things. And we just like to blame it on Lewy. Sometimes Lewy can be a jerk. And so the eye exam will look normal, but the brain is having trouble processing that visual information. And then we talked about those cognitive fluctuations being a hallmark feature of Lewy body dementia. So this graph kind of shows and illustrate what that could look like. So notice how that red line goes up and down. It's very unpredictable. So families often describe this as good days and bad days, but as you can see here, it can also be good hours and bad hours. So someone might be alert and engaged in the morning, then an hour later seem kind of drowsy, zoned out, confused. And so these changes can happen within the same day, within the same hour. And when people are alert, they can feel like their old self. When they're in a low state, that mean they might struggle with their train of thought, might feel a little or appear disorganized. And it's always key to remember that this is not the person living with Louis' fault. It's the disease causing these fluctuations. And so this unpredictability can make planning really hard. So if these ups and downs occur, trying to schedule more important conversations or activities during the periods of clarity, and more importantly, always being kind to yourself and to the individual, um, and that these changes, again, are a part of Louis. So moving on to movement challenges, these symptoms can look similar to Parkinson's disease. We have our bradykinesia, which is slowness of movement, rigidity, feeling that muscle stiffness, potentially a slow shuffling walk, and difficulty with balance, which can lead to a lot of repeated falls. Sometimes we have tremors, a resting tremor, but it's much less common in Lewy body dementia than in Parkinson's. So if you don't see it, that doesn't rule out Lewy. Just something to note there. And then often we see some myoclonus, which are those sudden jerky movements, or a decreased change in facial expression, which can make someone look like a little less animated or potentially appear to be upset when they're not. So, because we're dealing with concerns with balance and gait, fall risk is a big concern. So, early intervention with our physical therapy team and our occupational therapy team for home safety strategies and fall prevention is critical. Sleep changes are another major feature of Lewy body dementia, and they can start years, even decades before other symptoms appear. So, one of the most important sleep issues to know about is that REM sleep behavior disorder. So, when someone acts out their dreams, moving, talking, sometimes even hitting or kicking during sleep, and this is considered a core clinical feature, and it can show up between 15 to 20 years before cognitive symptoms. So, if you hear about vivid dreams or acting them out, that's a big clue to take a closer look at what's actually going on. Other sleep problems include insomnia, where people have trouble falling asleep, staying asleep, restless leg syndrome, where those uncomfortable sensations and kind of that urge to move at night can occur, can be pretty painful. Um, and these sleep changes don't just affect the person. I think it's also really important to note that they impact the care partner too. So imagine trying to sleep and your loved one is thrashing or kind of waking up repeatedly. So addressing sleep is critical for managing LBD. There are some pharmacological medications or treatments that can help for these sleep symptoms, but always talking with your healthcare provider and knowing how your meds interact before starting anything. And then another area that Lewy body dementia affects is the autonomic nervous system, the part of the body that controls a lot of our automatic functions like blood pressure, digestion, temperature. And these symptoms can often be surprising because they're not what most people think of when they hear dementia. So we can even see loss of smell. And this is also a symptom that sometimes years, 10, 15, can occur before other symptoms. Blood pressure fluctuations, especially drops upon standing, which can cause dizziness, fainting. And a lot of these can linger in Lewy body dementia versus just being like a quick episode. Temperature regulation issues, feeling too hot or too cold without a clear reason, constipation and urinary incontinence, which can be very challenging just to navigate during daily life, drooling, swallowing difficulties, even a runny nose that seems unrelated to allergies can be quite bothersome. And then we have abnormal sweating, which can happen even when the temperature is comfortable. So these symptoms often catch families off guard. Often they can be uncomfortable to talk about because they seem unrelated to our memory, but they are still very much a part of Lewy body dementia and can really impact quality of life. So managing these types of symptoms often mean working very closely with your healthcare team, sometimes adjusting meds. There are several non-pharmacological treatment options. So for example, blood pressure, can you move your legs a little bit, kind of prep your body before standing? Always being hydrated. Um, so there are some things that your healthcare team, your outpatient therapies can work with, but these should also be recommended on a individual basis. And then a big category here is our psychiatric and behavioral symptoms. And so these can sometimes be the most distressing and challenging symptoms for our families, and they often appear pretty early in the disease. So one of the most common we hear about is visual hallucinations, and up to about 80% of people with Lewy can experience them. So these are very well formed in details. Sometimes they're not always frightening. Sometimes they can be very comforting or benign or just kind of passing through. So, like seeing children, small animals, or maybe a beloved pet. Sometimes they're, again, like not very fearful based, but they can also be very frightening. And this is where it gets a little uncomfortable for folks. And not just only are there visual, but there's also auditory. And sometimes the auditory hallucinations can kind of be like a soundtrack for the visual. And that's where folks can really feel like this is real, this is happening because of that multi-sensory system. There's also taste and even touch hallucinations that can occur. We also see illusions, which are misinterpretations of real objects. So, for example, like if there's a coat on a hanger, sometimes that can be mistaken as a person. And then there's also delusions, which are fixed false beliefs. And there's several types of delusions that are related to Lewy. And sometimes there might be where someone thinks that their spouse is an imposter. It's called capgra or capgrass, depending on who you're talking to. There's also a delusion of spousal infidelity, or maybe that someone's trying to steal or harm them. So these can lead to paranoia and a lot of anxiety. Other behavioral changes that we can see in Lewy is apathy, and this is what we is loss of motivation. It's different from depression. Um, Also anxiety and depression, which are very common. So understanding that these symptoms are a part of the disease and they are not intentional can really help families respond with patience and compassion. So oftentimes when these occur, really trying to gently acknowledge, maybe reassure safety and redirect versus any argumentative or denying things can be helpful in certain situations or scenarios. If it's the right situation, creating a calm environment, maybe adding some good lighting to bring visual acuity up versus like a dimmer room, minimizing clutter. This can help reduce illusions and confusion. And then making sure we talk to the healthcare team early because a lot of these symptoms, there are medications that can help manage and reduce a lot of them. All right. And then with our behavioral and psychiatric, there becomes a lot of medication sensitivity that is a very critical topic for this population because the wrong medication can really cause some serious harm. So people with LBD are extremely sensitive to certain types of drugs like traditional antipsychotics like haloperidol or Haldol. These medications block dopamine and can cause a severe worsening of movement symptoms or even a life-threatening condition called NMS, neuroleptic malignant syndrome. So this can be a high fever, muscle rigidity, and kidney failure. And even some over-the-counter medications like diphenhydramine, which is often an allergy, or sleep aids, they can also cause confusion, increase the fall risk, and medications used for anxiety, like benzodiazepines, can actually make cognition worse or increase agitation. So, so this is the tricky part. Even medications that can help with the movement symptoms, like levodopa, can sometimes feed into and cause hallucinations. So medications are a big topic for someone living with Lewy, and they do require a very careful balance and kind of keeping a symptom log.
Okay, it's time for our third poll question, and it is many traditional antipsychotic medications can be dangerous to Lewy body disease. Okay, once again, many traditional antipsychotic medications can be dangerous to the person with LBD. All right, it looks like people are weighing in quickly, which is great. Let's go ahead and share those results. And once again, you're doing an excellent job, audience. Thank you. And back to you, Rachel.
And so we've gone over several differences between Alzheimer's disease and Lewy body dementia. And here's just another slide that gives a side-by-side comparison, a little reminder summary. So, whoops, got a little slide happy here, so we can kind of take note of the differences side by side with these two. And then I want to switch gears and go into unique challenges that come with Lewy. So, one big difference is the loss of independence. And so, this often appears earlier in LBD than in Alzheimer's. So, even when cognitive test scores look similar, people with LBD may need more help with daily activities because of the movement problems, the fluctuations in thinking, and the behavioral symptoms. And this more rapid decline in functional ability means there's an increase of dependence on care partners. And this can lead to higher resource use and cost of care. And studies show that people with LBD generally have more severe behavioral symptoms and more compromised functional abilities. And what does this all mean for our families? And it means that planning for support needs to happen earlier because of the combinations of all the symptoms we just touched on. And it really does require a comprehensive care approach. One of the challenges we see in Lewy body dementia is an increased risk of falls. And this often happens earlier in Alzheimer's and earlier than Parkinson's. And it's usually from a mix of factors. So we have these movement changes we discussed. So like that stiffness, slowness, the visuospatial difficulties, not being able to see edges of steps or things on the ground if there's a lot of clutter. And we have the cognitive fluctuation. So that day-to-day being on or maybe being kind of a little zoned out. And then maybe even the blood pressure drops. That's also going to factor in. So all of these together can make balance and walking more difficult. And that's why it's really helpful to keep an eye out for these changes in mobility and balance. And if someone seems unsteady or has already had a fall, because oftentimes a big risk factor of falls is having one to begin with or a fear of falling. That's a really good time to talk with our care team about options like physical therapy or maybe a home safety evaluation for adjustments. Simple things like better lighting, removing those floor rugs, those can be a big difference in getting around the house safely. And then falls can lead to injuries and hospital visits. So noticing these changes early gives us a chance to really reduce the risk and keep life as safe and as comfortable as possible. And research shows that for individuals with Lewy body dementia, particularly in men, the time to nursing home placement can be much shorter than those with Alzheimer's disease. So sometimes only even after about 2 years from diagnosis. So several factors can contribute to this early nursing home admission, and it's the complexity of symptoms that can make care at home very demanding. In addition, the use of antipsychotic medications, so often prescribed for those hallucinations or agitations, they are linked to an increase in admission. And then once admission happens, people with LBD tend to have a higher mortality rate compared to those with Alzheimer's disease. And this really highlights the importance of planning ahead and ensuring that care teams understand the unique needs and things to avoid. And we'll get into a resource that we have for that. And then one of the biggest concerns when individuals are in the nursing homes is that medication management. So many providers may not be familiar with the sensitivities, and certain medications, as we discussed, do have severe complications. So advocating when appropriate, sharing educational resources with staff, and then ultimately that awareness and the proactive planning can keep people safe. So I really like this article as well, highlighted on this slide. And then, just as you can imagine, all the things we've been discussing in the last so many minutes really pose such challenges for our care partners. And the literature speaks to that. So I wanted to shift this slide and our focus now to the care partners, because Lewy body dementia doesn't just impact the person living with Lewy, it's also those who help and support them. So research shows that care partners for people with LBD report moderate to severe burden, and many feel misunderstood. In fact, 80% of people from this study felt that people around them didn't truly grasp what they were going through. And more than half reported feeling isolated. And that kind of goes for all dementia care partners. Spousal caregivers often experience the greatest burden, yet only a small percentage, less than 40%, use respite care, adult day programs, or attend a support group. And so even fewer hire in-home assistance. And so whether that's funding, accessibility, but this lack of service utilization happens despite 2/3 of care partners reporting medical crises, requiring emergency services or psychiatric care. And then, I think this is a really good article to highlight as well. This Galvin and colleagues from 2010, if you get a chance to look at it. But really, I think supporting care partners means encouraging them to seek help early, whether that be through our community resources, support groups, that's someone they can talk to, talk things through that are going through similar situations, professional services, respite, and really connecting people with others who understand can make a world of difference. And then this slide really illustrates the level of assistance people with Lewy body dementia often need and how certain activities may become restricted over time. So for more complex tasks like shopping or cooking, over 90% of individuals with Lewy are unable to perform these activities independently or do require some substantial help. So even with basic activities such as dressing or bathing, more than 60% needed assistance. And driving is another area that's often affected early due to some of those vision difficulties or hallucinations or those cognitive fluctuations like we talked about. So all of these changes can feel overwhelming, and it's important to remember again that they're part of the disease process. It's not a reflection of any effort or ability. And so really building a strong care team and exploring resources early can really make a big difference for people maintaining safety and quality of life. So when we talk about the treatment for Lewy body dementia, the main goal right now is really to improve quality of life. There are no medications that can stop the progression of the disease, but the good news is that many of Lewy's symptoms can be managed or reduced with the right combination of medications and therapy. So again, this is why getting an accurate diagnosis is so important early on, so we know what we're dealing with and we can really create a plan. And treatment is about finding that balance. So finding the strategies that help the person living with Lewy feel more comfortable and as supported as possible, while also easing the burden from the care partner. So while we don't have a cure yet, we do have tools that can make a meaningful difference in day-to-day life. And looking at this whole picture, so this image really highlights the key factors to consider. So each of these areas can impact daily life, and a lot of them can overlap, as we've discussed. So, for example, those movement challenges can increase fall risk, cognitive fluctuations can make planning things harder, whether it's social, medical, or just daily hobbies, daily tasks. Sleep disturbances and autonomic symptoms can really add that additional layer of complexity. So, creating a care plan that addresses all of these aspects and really thinking about all of these for Lewy in a comprehensive approach way. Managing Lewy is not just about medications, it's also about building this strong interdisciplinary care team. So, often including nursing, physical therapy, occupational therapy, speech therapy, social work, and counseling, just to name a few. And often when I work with folks, they can say, "Oh, no one referred me." And really, and we have to be, educating our care team as best we can, being our own advocate, and if really knowing who to look for. So we have a couple of resources where you can find good therapists who are trained, have a neuro background, so that you can get the help you need. And then each discipline really does have a unique role. So helping with fall risk for our PT and OT crew, supporting communication and swallowing safety, avoiding aspiration from our speech crew, and then maybe some counseling, emotional support from our social workers and counselors. So the goal is to collaborate, bringing all of these professionals together to address the wide myriad of symptoms that exist. And so at LBDA, our mission is simple, but it's very powerful to improve quality of life for those affected by Lewy body dementia. And we do this by accelerating awareness, advancing research for early diagnosis and better care, and providing comprehensive education and compassionate support. Everything we offer, our resources, programs, and our advocacy comes back to this goal. We also partner with more than 20 leading academic medical institutions across the country through our Research Centers of Excellence network. And these centers connect families with highly specialized physicians and research opportunities, increasing access to quality clinical care, as well as just creating really an infrastructure for advancing LBD research. So this collaboration ensures that people living with Lewy have access to the best possible care and treatments. And if you're interested in research, LBDA offers the Lewy Trial Tracker. So it's a free resource that keeps you informed about clinical trials and studies related to Lewy. Anyone living with Lewy, care partners, healthcare professionals, and researchers can sign up. It's a great way to stay connected and updated with the latest research and how to participate. We also provide a wide range of educational materials, brochures, guides, handouts, videos to help families and professionals understand Lewy. These resources are designed to be practical and easy to share. And the other aim is really to promote confidence in navigating care and planning ahead. And so this right here just shows 3 examples of a couple of my favorite handouts. So we just updated our visual guide, the Seeing Through Lewy. I love this middle graphic handout. It really does look at Parkinson, Alzheimer's, and Lewy side by side comparison. And then we have a Lewy Who, which talks a lot about similar topic of today's presentation. We have a community webinar series, and for 2026, it's titled Insights, Innovations, and Everyday Impact. And these webinars are free and open to everyone. And it's a great way to learn on various topics. I mentioned earlier a little bit of a historical piece. And our next webinar is January 28th. We will be in Rochester, Minnesota. And we're taking our webinars on the road. But we are going to do a launch from there. We'll have a neurologist from Brazil who will describe historical points and his co-authored article about Dr. Lewy and his history. And then we're also having a live in-person event from Mayo with a very amazing and astute panel about the social economical platforms as well. And to help folks follow along with our webinars, we do have this engagement worksheet that you can download. Whether you're watching it live or catching a recording at a later time, it just helps to take notes, jot down key points, and refer back to it later. And then we have a couple on-demand learning options. And so we do have a YouTube channel. We call it LBDA TV. And you'll find educational videos of a variety of topics from simple symptom management to care strategies. But it's a really great resource to hear from a lot of our scientific advisory board members and other clinicians from all over talking about evidence-based care for Lewy. And then we have the Lewy Learning Center, which is another on-demand option. It's with the Thinkific platform online, and you can watch these videos anytime, share with others, and revisit as much as you'd like. For example, our community series, we have a redefining intimacy course, a course on exercise, vision, and supporting meaningful engagement. And then for our professional course, we have a Caring with Confidence course and a specific course on the Diamond Lewy Management Toolkit. And then another great resource we have is Spark. So just learning about Robin Williams and his battle with LBD. It's a documentary and it offers really an honest look at the challenges that they went through, him and his wife, and the importance of awareness and early diagnosis. And this is free to watch on Mediflix channel. And then we partnered with Mayo Clinic, and here is a course for healthcare professionals, and covers really anything from diagnosis to management, but it does provide continuing education credits. So it's a really great resource for clinicians to deepen their expertise on Lewy. And I mentioned the Diamond Lewy Management Toolkit. So this is for clinicians, and it's just a little snapshot of a booklet. We do have a downloadable version, a one-pager version, and then the Lewy Learning Center course to accompany this management. And it highlights medications to avoid, maybe some medications to consider, but it's a really great guide work. And then, LBDA, we have a very active online presence. So feel free to follow our social media platforms for webinars or events. And you can kind of see our handles right here, but to stay informed, share experiences, and connect with others. And then finally, LBDA provides direct support through virtual and community-based groups. So we have our Lewy line, which is a helpline. It is not a hotline where it's open 24/7, but they are very timely, and there are 3 amazing social workers who work the Lewy line. So whether you need support on general information, emotional support, or finding resources, we are here for you, and that is our phone number and our email address. Oftentimes these folks receive an inquiry and they are able to check in with other divisions through LBDA that are appropriate to answer the questions. And before we wrap up to the Q&A, I just wanted to review our key takeaways. And so first, Lewy body dementia is a complex, common form of dementia that brings a lot of unique challenges. Having an accurate diagnosis is critical, and it provides clarity and helps build the best management strategies. Second, building a comprehensive care team is essential. LBD affects thinking, movement, behavior, and sleep, even autonomic functions. So care needs to be multidisciplinary to address all of these. And then finally, education and support make a big difference. So not just for someone living with Lewy, but the care partners and family members as well. The more we understand this condition, the better we can plan, advocate, and improve quality of life. So resources and support are available to help navigate these challenges, and connecting with them early can really make planning and daily life more manageable. So with that being said, I wanted to thank you again for your time and attention. on this topic.
Yeah, and we have questions for you, Rachel, and I'm aware that we are very limited on our time. So before we go into the questions, I just quickly want to thank our sponsors once again, O'Connor Mortuary, Care Choices Hospice and Palliative Services, Caring Companions at Home, and Alzheimer's Orange County. And I want to remind everyone of our webinar next month which is on Tuesday, February 10th, and the topic is understanding anosognosia. And that is when a person has a very limited awareness of their diagnosis or if anything is wrong. So actually, Rachel alluded to that earlier in her talk with the Lewy body population. So let me go ahead and quickly ask the questions, and if we run out of time, please be aware that you can email Rachel and her team at support@lbda.org. So, first of all, are there links between autism and LBD?
Oh, I am not versed in that. That I am unfamiliar with any data to support that, but I am happy to look into it further with our education team and and report back on that.
Yeah, I think that because of the flat expression,
Yeah,
sometimes people think of autism or so that's a good question to do further
yeah,
research on. Thank you
yeah.
so much. Is there a genetic predisposition to LBD, Rachel?
Oh, that is another good question. Um, so as of now, there are a few genes that are known to increase the risk for Lewy. However, we know that if you have those genes, it doesn't necessarily mean that you will 100% have Lewy body dementia. And so that's still being looked at right now, researched. It's a little out of my scope, but I do know that there are several genes that are related and with Parkinson's as well, that can be risk. You know, and the long answer short would be, nothing right now is a definitive for that. We do know some folks have multiple family members who have the disease, and so we suspect, but not in today's day and age do we have a specific gene linked to this.
Thank you, Rachel. Why are symptoms more complex in men? You talked about how this can lead to early sniff admission, etc. So,
Yeah, that is such a good question too. And also that's the hard part about Louis is, from 2015 to now, we've exponentially advanced how many clinical studies and research articles are about Lewy, but for such a long time, a lot of these studies were excluding folks with dementia. So some of these questions
right.
we just don't currently know. And as far as men, we don't know why that's occurring, but we just noticed that we see more men diagnosed with Lewy than women.
Thank you, Rachel. Um, I have a question here about the research centers of excellence. Are there any of them located in California?
Yes, and what I will do is LBDA has a map, and a lot of our RCOEs are on the coasts or near big towns. And so, yes, we do. Um, and I can give that to Kim and Lauren to provide that information for you.
Thank you. And is it on your website? Because we could also refer people to the website.
Absolutely. Yep. So if you
Oh,
go to the website, there is a map and it'll show all of our RCOEs by state.
great. Thank you, Rachel. Um, little help with some of these definitions, please. Could you clarify? Um, let's see, where did all of a sudden I lost that question. Let me see. Here we go. Bradykinesia, first of all.
Absolutely. Yeah. So bradykinesia, Brady meaning slow and kinesia meaning movement. And
Okay.
so such a good question. This This is part of what we call Parkinsonisms, and they're a set of symptoms that when we see these occur, they're called movement symptoms. And so for bradykinesia, that's real someone moving really slow. It can be in legs, it can be the arm. We can even have bradyphrenia, which is slowed thinking.
Thank you. Uh, dysautomania.
Yes, dysautonomia. And
Thank you.
yeah, I tomato, tomato too. So depending on who you talk to, they might pronounce it a little different. You're doing great. Um,
Thank you.
so our autonomic nervous system are those automatic functions, and dys is abnormal. So those are just a little out of whack. And those autonomic functions or automatic functions in our body, it could be blood pressure, temperature. And so dys means it's out of regulation or it's not working properly.
Okay. Oh, so you mentioned like this abnormal sweating and some of those other features, right?
But runny nose is a
Runny
big
nose.
one.
Okay.
Urinary incontinence.
Okay. Thank you. Myoclonus.
Myoclonus is sudden jerky movements, and you can see that in different limbs. Also, a movement disorder symptom.
Okay. So just this is my question. Do you see myoclonic seizures happening in folks with Lewy body?
No, I
It's
personally have not.
it's
No,
just the movements.
more of like a hand jerking or legs.
Okay.
Yeah, but good
Okay.
question. Yeah, because there you could hear that with different types of diagnoses.
Okay. Let's see. All right. I'm going to read this. I'm not sure I understand it. Psychiatric slash behavioral symptoms, colon. Would meanness or oh, I get it. Okay, so would meanness or out of character vulgarity be a symptom of Lewy body? Or might
So
this just be related to the confusion or frustration that they're having
that's
with their environment?
such a good question. And those are a part of the psych and behavioral. There can be some agitation, some confusion, frustration just from managing the symptoms. But yes, that can occur.
Thank you. My husband's Parkinson neurologist just says he doesn't respond to Parkinson meds, so there is no name to his Parkinson's. So I don't know if it's Lewy body. So how can I advocate to get tests to know specific um,
Yeah.
dementia? Okay, so to break that down, they're just asking. They're just saying their physician doesn't have the knowledge, and so is there a way to educate them? How can they advocate for him to make a determination if it's Lewy body?
Well, great question. And you're already well on your way to being a great advocate for this loved one. So kudos, asking great questions. And so, this is what we see too with some of our healthcare providers. Like the older kind of way of thinking was, we've heard it doesn't matter what type of dementia, there's nothing we can do kind of thing. And it's unfortunately that's not true. There's a lot we can do, as I've alluded to in today's presentation. But I think, about your question and what I might advise is maybe to check out those symptom checklists. And there's one targeted towards family members and see if you can tick mark any. And that might be a good conversation starter to say, hey, I think something else is going on. Or maybe it'll give insight that what you're doing is going well, but use the checklist for sure.
And on the heels of that, our final question, it's really an observation. It's just about medical personnel, like in hospitals. This audience member had a bad experience with mom and dad being in the ER and staying in the hospital. She's found herself having to educate everybody, the nurses, the ER staff, everybody around her in the hospital. So, is there
Mm.
any kind of training effort underway for hospital personnel?
Oh,
On Lewy body dementia.
So that is such a good point. We unfortunately hear that all too often. We have a couple initiatives in 2026. We're going to be doing kind of a pilot program, and we're going to start with a couple medical centers and really push education for these providers. And we're going to see if we can pair with a peer mentor, and creating a couple deliverables with that program. One being, certain healthcare letters. A medical alert bracelet, medical alert card. So those are underway, and we're happy to share those things that we can share to this group when they are ready. I will say that Diamond Louie slide that I went to, that is for clinicians. And so right now, our marketing team is actually creating a little brochure, and it will have a QR code to the full Diamond Louie toolkit. And then we do have that one pager and a trifold brochure. Man, if we could get those in the hands of every PCP, that is our goal. Because just like you mentioned, it's a lot of advocating and we're up for the challenge, but we are creating some of these resources to get people in the know. And hopefully I highlighted that today of why early diagnosis is so important. But I would say that Diamond Louie toolkit, please go to our website. It's downloadable, printable on the Louie Learning Center. There is a course, and so you can even drop that off with any of your loved ones' care teams, send them our way. And then, yeah, I will try and circle back about some of those deliverables for like hospital care safety, physician letters in the future.
Great. Rachel, I want to thank you so much for coming to be with us today and sharing this incredible information about Lewy body. Also want to thank you for sponsoring our monthly support group, which meets twice a month on the first and third Tuesday at 1 o'clock, especially for people who are caring for someone with Lewy body and some other difficult diagnoses as well. So we appreciate collaborating with you on that effort, and we're so happy that you were able to be with us today. I just want to say that this brings us to the conclusion of our webinar, and I think we've kept you here a couple minutes extra, Rachel, and we appreciate that. So we thank you for sharing your time and your expertise with us.